So tumors are basically abnormal proliferation of cells. Okay, they can be benign or they can be malignant. Benign tumors means usually the cells retain the original differentiation. They might be abnormal for that site, like where you expect a bone tissue to be there, comprising of osteoblast, osteoclast, and osteocytes. Instead of that, you will have cells like fibroblasts. Okay, although they are part of the body, they are part of the normal structure of the body, but the site is abnormal. Hence, they are called tumors. Okay, so any neoplastic growth, any rapid proliferation of cells is a tumor. But all tumors are not cancers. Okay, few tumors which have malignant potential. Malignant potential means invasiveness. That is, they have an ability to destroy the surrounding architecture, able to locally infiltrate other normal tissue and destroy it, and ability to metastasize means ability to spread from one part of the body to another part. It could be from bone to bone, or it could be more commonly from bone to lungs, livers, and other visceral organs. So these are aggressive tumors and they are called malignant because of their inherent potential of invasiveness. Agreed? So almost all tumors have benign and malignant types. So according to you, which is more common? Yes, benign, correct. So benign tumors are relatively much more common compared to malignant. Okay, because malignant tumors, they arise in particular scenarios. Like benign tumors can be abnormalities during the process of differentiation, during the process of development and growth. Malignancy arises only when there is mutation in the cell. Okay, there will be specific mutations which will lead to malignancy, and then these tissues will again invade and spread. Clear? So the most common age group for bone tumors is 40 to 60. Okay, although this statement is not completely correct. 40 to 60, why we say when we consider even metastatic bone tumors as part of bone tumors. See, the most common bone tumor even today is metastatic bone tumor, means it is not the inherently primarily a bone tumor. It is a cancer which has spread from somewhere else. It could be a lymphoma, it could be lung cancer, it could be kidney cancer, it could be oral cancer, which has spread to the bone and led to swelling and neoplastic growth in the bone tissue. So that's why the most common age group is 40 to 60. But if you consider primary bone tumors, means the tumors which have arisen from the bone itself, then the most common age group is the adolescent age group, which is the teens. Okay? Any idea why? Correct. So the reason is this, because when the kid starts growing up, there will be phases of rapid growth. Like for a female, it is around 8 to 10 years, and then 14 to 16 years. For males, it is around 10 to 12, and then 16 to 18 years. These are the phases of life when you will have rapid skeletal growth. During this time, when the tissue is rapidly dividing and generating, at that time there might be some errors which might creep in the genetic tissue. Okay, the DNA might change, there might be some alteration in the DNA tissue, which might be unchecked. See, usually what happens, every second of the body, some of the cells will be dividing, that you are aware of. Correct? Sit down. So the gastrointestinal lining, it is rapidly dividing cells, the hair follicles, the skin. Okay? Body has an inherent mechanism to check for faults. It is like a basic quality control check. Okay, so the body has a quality control check where if it finds any error or any discrepancy from normal tissue in the rapidly dividing cell, it kills it. Okay, but when the process is very fast and there is lot of tissue which is growing, like which happens during growth phase, then sometimes this quality control check is not capable to handle that growth, and few of the cells which might have a discrepancy in the DNA or which might have a structural change might escape this quality control and they might continue to grow. So these nests of cells might later lead to neoplastic growth. Okay. So As you see, the most common site of bone tumors is around knee joint, because femur is the largest bone in the body, largest long bone in the body, and tibia is the second most. And the maximum growth, longitudinal growth among the long bones is contributed by distal femur and proximal tibia. So correspondingly, the amount of tissue generated by these two bones will be large. Okay, so this is all in hypothesis. Okay, this is not something which is proven, but this is what, when you go in research, when they say that what could be the reason, this is one of the probable causes which is thought of. Okay, considering everything, although there is no way to prove it. Okay. So these are some of the common types of bone tumors. The most common is osteochondroma. Okay. Among benign bone tumors, we usually use a classification where we have benign tumors, there are latent tumors, and there are active aggressive tumors. Okay. So osteochondromas usually don't grow once you have attained skeletal maturity. Okay, means once your growth plate is fused, the physis is completely fused, they won't grow. If they start growing after you have attained puberty, after your growth is complete, then usually it is due to secondary malignant transformation. Okay, so that's why these patients, some of these will be like hereditary multiple exhaustion is one condition in which patients tend to develop lot of osteochondromas. They will have multiple osteochondromas. So among these patients, the risk of malignant transformation is around 5%. Okay, so out of 100, 5 will develop malignancy at some point of time. So these patients are usually kept under active surveillance. Means every year they have to come for a checkup, even though they might be completely asymptomatic. Because it is better to detect these swellings if they are turning malignant at an early stage, because at that time treatment is possible. Once a bone cancer, means a malignant bone tumor metastasizes, the probability of curing the disease is next to nil. Okay, the 5-year survival of a non-metastatic bone sarcoma after completing treatment is 70%. But if it becomes metastatic, the 5-year survival crashes to around 20 to 30%. Okay, so that is a significant fall in the survival. So it is better that these patients are picked up early and treated early before the tumor has a chance to metastasize. Once it metastasizes, you are basically fighting a losing war. Okay. Among the benign bone tumors, not all bone tumors require treatment. Like I said, osteochondroma is one of the most common bone tumors. But not every osteochondroma has to be treated. Okay. Because basically osteochondroma is treated surgically, means you have to excise it completely. But if the patient is asymptomatic, if it is not hampering his activities of daily living, then you are not supposed to operate on it, you are supposed to just observe it. There are very few indications in which we suggest surgical removal of osteochondromas. What could this be? Any thoughts? That is one, malignant transformation. But then if it is a malignant transformation, then it is not an osteochondroma, right? Then it is a malignant bone tumor. So for a benign bone tumor to operate upon it, can you think of something which... Sorry? Cosmetic, correct. Then pain, correct. But does every painful osteochondroma need to be operated? Yeah, it is compressing. So compression of the surrounding neurovascular structures. See, osteochondroma around the proximal femur, which is pressing on the sciatic nerve. Okay, sciatic nerve goes posteriorly, right? Everybody is aware of that. So if there is an osteochondroma in the proximal femur and the sciatic nerve is lying just beneath that, so whenever the patient sits, the patient will have paresthesia because the sciatic nerve undergoes compression. Now he is not able to sit, so how do you expect him to do all his activities of daily living? If he is in a profession where he is required to sit on the job for a prolonged period of time, he will not be able to do. If he is a driver, if he is a clerk, how is he going to live and earn his daily living? So in those scenarios, even though it's a benign swelling, but because it is causing neurovascular compression and causing significant distress to the patient and preventing him from doing his activities of daily living, that is a good cause for opting for surgical management. But suppose a patient comes who has occasional pain in the around the knee joint, and when you take an X-ray, you find that there is a swelling which is consistent with an osteochondroma, you are not going to offer him surgery immediately. You have to first find out the cause of that knee pain. See, knee pain is a vague symptom, right? It could be because of multiple factors. It could be the kid might have fallen and sustained injury to the knee. It could be growing pains. It could be something else. Okay. It could be that he is standing for a long time and then he develops pain. So then finding out the exact cause of that pain is extremely important before you are embarking on a surgical procedure. They are saying, right, do no harm. Okay. So surgery by itself comes with risk, especially in young kids. See, these osteochondromas are usually diagnosed in kids. Okay. And these are the growths which are lying very close to the physis, that is the growth plate. So the standard dictum is when you are going to excise them, you are going to excise them with the periosteal layer which is overlying it, so that you ensure complete removal. But in that bargain, there is a risk that you might injure the physeal arterial supply. So long term, the patient has a chance that he might develop deformity, for which he may need another surgery in the future, or the growth of that limb might be hampered, so that their patient may have a risk of developing limb-length discrepancy. So you have to consider the risk, you have to consider the benefit, you have to find out whether the symptoms are distressing enough or causing significant distress to the patient, which leads you to offer surgical management. Otherwise, most of these patients, if there is no neurovascular compression, the swelling is not rapidly growing, except for cosmesis also, the one which madam told, we wait. Okay. Even for cosmetic deformities, we wait till the child attains skeletal maturity, so that after that we can excise it. Okay. So these are the conditions in which we have to wait. Okay. So not all tumors need surgery. Like a mole is also a tumor, right? I have a mole over here. This is also a kind of a tumor. But I am not going to excise it unless and until it starts showing signs of pre-neoplastic lesions, or it is showing signs of malignancy, like it rapidly starts growing inside, starts bleeding. Then only I will opt for it to be removed. Correct? But if you are too concerned about cosmesis, you are at your will to get it removed. But you have to understand the risk as well as the benefit. So same thing applies to all tumors. Okay? So the second most common is osteoid osteoma. Okay? Osteoid osteoma are basically cortical or periosteal based tumors. These are extremely symptomatic. Okay? These tumors cause significant night pain. The child starts limping. If it is near the joint, there will be rapid synovial effusion. So these are the patients who require treatment. Nowadays, in osteoid osteoma, we usually don't offer surgical management because we have intervention radiological methods like radiofrequency ablation, cryoablation, by which minimally invasively we can destroy the nidus of the osteoid osteoma and get it completely cured. The clue for treatment is that there should be a nidus which is visible on an MRI and a CT scan for a definitive diagnosis of osteoid osteoma. Okay. See, in bone tumor, there are something called a no-touch lesions. Okay. No-touch lesions means you are not going to touch them even for a biopsy. Means based on X-ray and clinical findings, you make a diagnosis, but you don't confirm it with a biopsy. Few of these lesions are like fibrous cortical defect, non-ossifying fibroma. These are basically islands of normal tissue in the whole structure of the bone. So fibrous cortical defect will have some areas where there will be fibrous tissue will be there instead of osteoblast and osteoclast, and the appearance will be characteristic. When you see the X-ray, you know that this is a fibrous cortical defect. When you see an X-ray, you will know that it is non-ossifying fibroma. So these are a few no-touch lesions in which we don't need a biopsy to confirm it. But osteoid osteoma is also same. If the radiological imaging is consistent and you are able to find a nidus, then you don't do a biopsy, you usually go for a direct radiofrequency ablation. But remaining tumors, we have to do a biopsy. Even osteochondroma for that matter, it's a radiological diagnosis. Okay? The features of osteochondroma, if they are present in a CT or an MRI, then you make it a diagnosis, you don't confirm it with a biopsy. But for aggressive benign tumors, you have to have a biopsy before you are embarking on a surgical management. So few of the aggressive bone tumors are giant cell tumor, chondromyxoid fibroma, aneurysmal bone cyst. Okay. So why are they called aggressive? Any thought? Yes? Talk louder, please. Rapid growth, correct. So these are the lesions which have a tendency to have rapid growth and cause significant destruction of the skeletal structure. They might grow so fast that they may completely resorb the native bone and cause pathological fractures. Okay, so that's why these need to be treated surgically at the earliest, and they have a tendency to recur also. Although they are not completely malignant, they are aggressive benign lesions, means they will destroy the native tissue, they will destroy the surrounding tissue. Very rarely they can metastasize. Like giant cell tumor, the risk of metastasis is around 1 to 2%, and most of the time it will metastasize to lungs. Okay, so if it metastasizes, then it is a life-threatening situation. Otherwise, if it starts growing rapidly, it can lead to a limb-threatening situation. So that's why these need to be treated. Okay. So coming to malignant tumors in bone, the three most common are osteosarcoma, Ewing sarcoma, and chondrosarcoma. Okay. Now, along with that, when we talk about bone tumors, we have to also talk about soft tissue tumors. Okay, because in extremity, sometimes when the soft tissue malignancies start growing fast, they might involve bone. Okay, so if the patient presents at a later stage, it becomes difficult to differentiate clinically whether the tumor is arising from the soft tissue or the tumor has initially arisen from the bone and then invaded the soft tissue. It could be both, right? A tumor arising from the muscle can easily invade the bone which is lying underneath, or a tumor arising from the bone can easily invade the surrounding musculature. Okay, so if it is at an early stage, it is very easy, means you will have minimal soft tissue component, the swelling will be mostly confined to the bone, so the diagnosis is relatively easy. But sometimes the patient presents too late. By the time the patient presents, the underlying bone is completely destroyed, there is a large soft tissue mass. So then the question arises, what is it? Whether it is a soft tissue tumor which has gone into the bone, or it is a bone tumor which has permeated into the soft tissue. Because the management is different, the prognosis is different. A Ewing sarcoma or a osteosarcoma can be treated even if it has a large soft tissue component, and the outcomes are relatively better compared to a soft tissue sarcoma. When you talk about bone malignancies, if it is a non-metastatic bone malignancy, primary bone malignancy, and you excise it and the patient receives adjuvant therapy, whatever it may be, chemotherapy, radiation therapy, whatever it is, the probability of the patient surviving is almost 70%. But when it is a primary soft tissue sarcoma, then the probability falls to 50 to 60%. So there is almost a 10 to 20% fall in the survival. Okay, so and moreover, the regimens which are used for treating bone sarcomas and soft tissue sarcomas are totally different. Means the drugs which we are using for a primary bone cancer are not always used in soft tissue sarcoma. Although there might be few drugs which will be common for both, but not every drug is used. Okay, so that's why a diagnosis before embarking on a therapy is extremely important. Because you need to know, see, whenever a bone tumor is diagnosed, first thing you have to find out is whether it is benign or malignant. Okay, that is the first question which comes to your mind. Then you have to see the extent of the disease. Okay, so to what extent the disease extending. So you have to take a radiograph and MRI of the affected limb. Then you go for a biopsy to confirm your suspicion that whether it is a benign or malignant. If it is a malignant, then one more step is added in which you do a staging. Means you screen the body to find out whether there is any deposit of malignant tissue anywhere else, whether the cancer is metastasized or not. Because a metastatic cancer, more often than not, will not be treated with curative intent. It will be treated with palliative intent. What is palliation? Palliate means to relieve. Okay, to relieve the symptoms. So palliate inherently means you are going to give only symptomatic treatment. The intent is not to cure the disease. Okay, so that is a difference. But curative intent means we are aiming for complete cure of the cancer, or because the probability of a non-metastatic sarcoma achieving complete cure is almost 70%. Anything more than 50, it is worth giving a shot. Okay, So that's why when you are talking about tumors, these questions should arise. It's not like you diagnose a tumor and you jump into immediately treating it. Okay? Because the treatment regimens are toxic. You need to be sure that what treatment you are going to give to the patient is actually beneficial for the patient, because the drug regimens are different, as I told earlier. The management is different. If it is already metastasized, then more often than not, you are not going to offer surgical management. Okay, you are going to give just radiation therapy or targeted therapy or immunotherapy and relieve the symptoms of the patient. But compared to that, if it is a primary bone tumor which is non-metastatic, then you are going to go aggressive. Whatever it is, you try to remove the tumor and give adjuvant therapy in the hope that the patient lies in the group of 70% who is going to survive the disease. Okay, so that's why in bone tumors, one thing you have to, if you have to understand is diagnosis is very important. You have to be sure whether you're dealing with a benign or malignant, and even then the type and the staging is very important before you are formulating a treatment. And most of the time, these treatments should not be offered at periphery because the wherewithal is not there. Like in cancer treatment, we require a lot of specialists. A simple bone sarcoma will require a medical oncologist. Okay, if it is Ewing sarcoma, he will need radiation, so he may require a radiation oncologist. The follow-up is long, so the patient should know the facility where the patient can come every time at specific intervals for checkups, because there is a tendency that the cancer may recur. You have heard, right, that patients would have been declared cured, and after 2 or 3 years again they say that my cancer has come back. Okay, so how is it detected? It is detected during follow-up examination, that is called surveillance. Okay, so whenever the patient completes a treatment, especially malignancy, the patients are put in surveillance protocol where they have to come at defined time intervals for checkups, where we check whether the disease has recurred or not. Okay, so for coming to metastatic bone cancer, I have already told you this is the most common bone tumor which is prevalent. Okay, the most common sources are lung. Okay, in India again oral cancers are there, then kidney, thyroid, breast, prostate. Okay, many a times see hormone sensitive tumors like breast and prostate frequently will present with metastasis at the time of diagnosis itself. Like in prostate also, because the diagnosis is delayed, many of the time the patient will have symptoms of urinary retention and other symptoms for a long time. By the time they are diagnosed, already the cancer would have metastasized. But prostate cancer, which is responsive to treatment, which is sensitive to hormonal therapy, we expect the patient had to survive for 10 to 20 years. Okay, so these are a relatively different kind of tumor. Nowadays, we consider that a prostate cancer diagnosis is not that bad if it is responding to therapy, because then you have drugs which can control the disease, and patients usually have almost a near normal lifespan, although they will have to do continue therapy. Breast cancer also, if it is hormone sensitive, with treatment the patient survives a long time. Okay, so that's why diagnosis is important. Lung cancer, if it is EGFR positive, nowadays we have drugs which can block that mutation and prevent progression of disease. So the 5-year survival is pretty good. So these questions, when the patient turns to the OPD, they will ask, what is the chance? Correct. Anybody who is diagnosed with cancer is going to ask you, what are my chances? What am I looking at? Am I looking at a 5-year survival or not? So that's why when you are going to answer these questions, you need to have these kind of data with you. That what is the type, what is the metastasis which is present, and what are the mutations which are there, and what are the therapies which are available, which can give a realistic survival advantage to the patient. Okay. So when a patient of bone tumor presents to you, the approach we have already discussed. So basically, imagine a kid 10 years old is brought by her mother complaining that she has noticed a swelling around the knee joint. Okay, and the child, she has noticed that nowadays the child has started limping, and after that only when she examined, she found a swelling in the knee joint around distal side. So how are you going to approach it? Yes. So what are the questions we are going to ask? You only, man. You're looking at me and you're sitting down. And no, not you, the one behind you. Okay, so what are you going to ask in history? See, when you're going to make a diagnosis, no, your family history is also important, especially in case of kids. Sit down. Like a hereditary multiple exostosis, the mother may have brought only one child, okay, telling that he has multiple swellings in the bone. So when you ask them, they will say, yes, another child is there, he is at home, but he is not having symptoms, so I didn't brought her. Correct? So that's why when you are approaching a tumor, you have to take a proper history. You have to know the site where the patient is having a bump. You need to know for how long it has been there, when the mother or the kid noticed it, whether if they are able to tell you whether it is growing very fast, what are the other symptoms, whether the child has recently started losing weight or the swelling has disproportionately grown rapidly over say a period of 6 to 8 weeks, and the child is not able to bear weight on the leg. So a kid who has been playing normally, who has had a routine childhood, suddenly starts limping, suddenly refuses to put weight on the leg. That is a warning sign. Okay. See, mechanical structure of the bone, unless and until it is more than 30 to 50% destroyed, it won't cause mechanical pain. So the bone tissue almost 30 to 50% has to be destroyed for it to be visible in X-ray. Okay, that there is some lysis or some structural changes in the bone. At least 30% of the bone tissue has to be altered, and 50 to 60% has to be destroyed for the patient to start having symptoms in which when he starts to bear weight, tries to bear weight, he will have pain. So if a kid is having severe pain while trying to bear weight on the leg, it is a warning sign. If the mother says that this swelling was not there 2 months back and suddenly it has appeared and is rapidly growing inside, it is a warning sign. Okay, so these are the red flags. Okay, another thing about it is you have to ask in history whether it is associated with fever and all. Other systemic symptoms are there or not. Because children have a tendency to develop infections. The infection may travel to bone and lead to osteomyelitis. What is subacute osteomyelitis in children called? Yes, CR. What are types of osteomyelitis? And there is something in the middle. Subacute, Brodie abscess is there, no? There is something called a Brodie abscess, which is present in kids. Okay, so you might have a osteomyelitis mimicking a bone tumor, and you have bone tumors which will mimic like a osteomyelitis. Like Ewing sarcoma, frequently people based on X-ray judge it to be osteomyelitis, do a debridement, and when they open it, frequently the character of the tissue is such that they assume it to be pus. Okay, so they debride it, they contaminate the whole site, and ultimately the child loses the leg because a contaminated tumor site, it is very difficult to achieve complete margins. Means it is even though the tumor might be non-metastatic, but because of local contamination due to debridement, more often than not, we have to do an amputation only to achieve complete tumor clearance. That's why when we are talking about tumors and even infections for that matter, nowadays presumptive treatment like empirical treatment, which used to be there say 20 years back, nowadays we don't opt for that. We have to confirm the diagnosis. So the only way to confirm a diagnosis is biopsy. Unless and until the tissue is taken and is seen under the microscope, you cannot definitely tell whether you are dealing with a bone tumor or something else. And even if it is a tumor, what type it is. So a pathologist has to tell you what is the exact diagnosis. And if there is a discordance, means you feel that this is not a bone tumor or this is an infection, but the pathologist is saying it is a bone tumor, there is a discordance in the radiology, the MRI, then everybody has to discuss it again. And if needed, you take a second opinion before embarking on a treatment. Because the treatment of osteomyelitis is totally different from a treatment of a bone tumor. What is the treatment of osteomyelitis? Yes, madam. How do you treat an osteomyelitis? Stand up, please. How do you treat osteomyelitis? You were there in TB spine lecture, right? So what do we do in TB spine? Right. Anybody? Yes, madam. How do you treat? It is infection, right? So what do you do for infection? And because it is tissue, then bone tissue, then there is something called debridement, right? Debridement, sequestrectomy, saucerization, and culture sensitive antibiotics. Correct? And tumors, totally different. We don't do debridements and all. Okay, if it is a sarcoma, it has to be removed. Sit down. It has to be removed in a single piece with a layer of normal tissue around it. Okay. So any lump which is more than 5 centimeters, the size of a lemon or a small orange. If anybody has a lump which is more than the size of a lemon and an orange with a short history, then unless proven otherwise, treat it like a malignancy. Okay, that is a basic dictum which you have to follow. Patient comes with you with a short history and you see a palpable lump which is at least 4 to 5 centimeter in size. The first differential in your mind should be a cancer. Okay, and after that other differentials come based on the history and everything. Okay, so these are the few presentations of how bone tumors present. So you can see this. What is this? And what is this? And what is this? Incision drainage, but then in bone tumors and sarcomas we don't do incision drainage, right? So what could it be? And for incision drainage, don't you think it is a very small incision?
So it is involved this skin.
Sorry?
So it has involved this skin also. The skin also.
No, man, these are surgical scars, no? This is also surgical scar. Yes, any guesses? Yes, madam? Synovial. And what? What is the question? So what are those scars denoting? Why are there scars on the tumors? No, we don't do drainage, right? Just now, for the past half an hour, we were discussing that you don't drain a tumor. What do you do? For confirming a diagnosis, what do you have to do? Biopsy. So how do you do a biopsy? You have to insert a needle, right? So that is a biopsy scar. Okay, that is a biopsy scar. Usually we do core needle biopsies. Okay, so in case of bone tumors, few rules we have to follow when we are doing a biopsy. Okay, one thing is the scar should be planned in such a way that it can be excised at the time of definitive surgery. What the first and foremost principle is the biopsy should be done at a center where the definitive management is being planned. Means if the whole treatment is possible, then only do a biopsy. If whole treatment is not possible, then you have to refer to a center where the complete treatment of the patient is possible. Okay, so that everything is considered before embarking on a therapeutic decision. Okay, then the site of the biopsy should be such that it could be excised. You should have representative samples. For that, you need to have X-rays, MRIs. In MRI, you have to see which is the part of the tumor which is rapidly growing. More often than not, in tumors, what happens? The tumor starts growing rapidly and the core of the tumor is necrotic. So if you take a sample from the necrotic component, the pathologist is going to tell you there is no viable tissue. I cannot tell you what is the exact diagnosis. So it is usually the periphery of the tumors which will have actively replicating cells. So in a MRI, you have to see which are the sites where the active replication is happening. So for that, we usually do a contrast enhanced MRI. So wherever the contrast uptake is there, usually those are the sites which will have actively replicating cells, and we target those areas to take a biopsy so that you get a positive diagnosis. Because if you don't have a diagnosis, then more often than not you have to repeat the biopsy. Unless and until there is a tissue diagnosis, you cannot treat it. You need to know what it is before treating it. Okay? So on clinical examinations, you have to look for the skin changes. So what is this? We forgot about this, no? What is that? It's a wound, right? Sorry? Tell me. Osteomyelitis sinus. But it is a bone tumor, no? We have established that these images are of tumor cases, not of infection. Any guesses? So, in rapidly developing cancers, if the biology is very aggressive, the tumor grows very fast. It invades the skin also and it ruptures to the skin. Okay, it completely breaks down that skin barrier and ruptures through it. Then it is called fungation. So, fungation, if it is there, then inherently, if and the duration of symptoms is short, then it denotes that the tumor is extremely aggressive tumor. Okay, because usually sarcomas which are there, that means primary bone tumors which are there, malignant tumors, they respect the facial planes. Means if it is confined to muscle, it will take a long time to completely invade the muscle and breach the fascia. Okay, but if it is breaching all the fascias very fast, then the biology is very aggressive. Okay, so this is called fungation, and if it is there, then it is a clinical sign that the tumor is very aggressive. Sometimes what happens, the patient initially presents with something like this. You're seeing that there will be a swelling in the knee joint. You do a biopsy. The biopsy turns out to be an osteosarcoma. You send the patient across to medical oncology guy to start chemotherapy so that the tumor shrinks a little bit and you can plan a management. Okay. After 1 or 2 cycles, the situation changes to this. So from here, the patient turns to this. So what does it denote? It denotes aggressiveness of the tumor. It denotes that the chemotherapy which the patient is taking is not working. Because if the chemotherapy would have been working, the tumor should have shrunk a little bit and should have responded. The fact that even after 2 cycles, instead of shrinking, the tumor has increased in size and breached the skin barrier and fungated, it means it is very aggressive and the chemotherapy is not working. So more often than not, these are the patients who will end up with an amputation. Even though primarily when they would have presented, the MRI image would have suggested that these are the cases in which salvage, limb salvage is possible. But after 2 or 3 cycles, once you see that the tumor is very, very aggressive, it has breached all the facial layers, it has encompassed all the critical neurovascular structures, then only option for tumor clearance left is amputations. Okay. So you have to look for skin changes like fungation is there or not, scar is there or not. If the patient has previous history of surgery, what is the site of scar, whether it is medial or lateral, because that will change your approach to excision also. Because see, tumors like in distal femur, you can go either by a lateral approach or a medial approach. Okay, it depends on how you're going to excise it. But if somebody has already contaminated that field by a medial approach, then you're forced to go by a medial approach only, because you have to remove that contaminated field along with the bone tumor. Okay, so that's why clinical examination is important in bone tumors, because it is going to have treatment implications also. Okay, then neurofibromas. Why neurofibromas is specifically written over there? Why neurofibromas is specifically mentioned? What are the types of neurofibromas? Homework for you all. Read about neurofibromas. Okay. NF1 and NF2. So what is the difference? So then the site, again where it is located, whether it is mobile or not. If it is mobile, then what does it denote? Not fixed. So then you are dealing with a soft tissue tumor. If it is not fixed to the bone, then it means it is not arising from the bone itself. Then it is more often than not, it is a soft tissue tumor. If it is fixed, it could either be a soft tissue tumor or it could be a bone tumor. Correct? So that's why fixation is important. So these are something which you will see on clinically itself, and then you have to confirm it when you are seeing the imaging. So the basic work we have already discussed. We take a limb X-ray. The limb X-ray has to be complete. Means if the swelling is in the distal femur, you're going to take the X-ray of the whole femur. If the swelling is in proximal tibia, you're going to take the X-ray of the whole tibia, not just their part of the swelling. Because there is something called skip metastasis, which might sometimes be visible in X-ray itself. Means there is a primary swelling in the around the knee joint, and there is a deposit of the tumor in the shaft, which has caused lysis. Okay, so that itself is visible. A skip metastasis again denotes aggressiveness. If the tumor is so aggressive that it is skipping into the same bone, then it means it is more aggressive. Okay, and the biology is relatively poor. And MRI, they specifically written something like tumor protocol. So tumor protocol basically means we are going to screen the whole bone itself. Like when you take an X-ray, you take the whole X-ray of the complete bone. Same way when you're taking an MRI, you're going to screen the whole bone completely. Okay. And tumor protocol also involves giving contrast, gadolinium contrast, because gadolinium contrast is going to light up the areas in the tumor where active division is taking place, where the cells are actively dividing, where the cells are viable, so that you can plan a biopsy. Imagine there is a very huge swelling around 10 centimeters. It is completely dark and only a small 2 centimeter focus is there, which is lighting up by giving contrast. So when you're going to take a biopsy, you're going to take it from the 2 centimeter rather than from the remaining 10 centimeters. Because if you target the 10 centimeter, it is completely necrotic. You're not going to get a diagnosis. You have to target the 2 centimeter area, which is actually picking up contrast, which is actually having viable cells, so that you come to a definitive diagnosis. Okay. And the baseline investigations, CBC, RFT, LFT, because biopsy is inherently a surgical procedure. You need to know the overall systemic condition of the patient. Okay. Then there is something called metastasis myeloma workup. So a person of less than 30 years of age presenting with a lytic bone swelling, okay, the first differential is not going to be a metastasis. But compared to that, a 40-year-old male or a 40-year-old female presenting with a bone swelling which is lytic or which is heterogeneous, then the first differential which we have to consider is the metastasis. Because again, going back to the first slide, metastasis is the most common bone tumor. Okay, and metastasis more often than not comes in patients who are in the age group of 40, more than 40 years. Okay, so age also matters, but metastasis is not going to be my first differential in a kid. A 10-year-old kid coming with a lytic swelling, with a swelling around the knee joint, I'm not going to consider metastasis as the first thing. I'm going to consider a primary malignancy. But same thing, same rule doesn't apply to an adult, especially one who is crossed 40. Okay, because more often than not, you won't believe it, many of the lung cancers, kidney cancers are actually diagnosed when the patient presents with a pathological fracture. Means the patient presents to us with a pathological fracture with a lytic lesion. Then when we screen them, we find out that there is a mass in the kidney or there are patches in the lung. So then we come to know that most likely he is having either lung carcinoma or a kidney carcinoma, and the patient is completely unaware. They will only present with pathological fractures. So that's why this metastasis has to be considered as your part of your differential if the patient is in the middle age group. And multiple myeloma also. Multiple myeloma basically leads to multiple diffuse lytic lesions. Punched out bony lesions will be there. There will be erosions. There will be lysis of the bone. Many of the time the patient present with a pathological fracture. So if the patient of 40 years is there, then multiple myeloma also has to be ruled out. So the test for ruling on multiple myeloma usually screening test is serum immunoelectrophoresis with immunofixation with free light chain assay. Okay, so you look for free light chains, you look for immunofixation, you look for the M band. Okay, so if it is there, then more often than not the patient is suffering from multiple myeloma, and the prognosis is totally different. Like we have discussed previously, a prognosis of a metastatic lung cancer is completely different from metastatic prostate carcinoma. Okay, in prostate carcinoma, if it is hormone responsive, you are looking at least 10 to 15 years, but a lung cancer maybe 5 years. So in that way also, it will influence the treatment decisions of yours, because the treatment is different and the way you're going to counsel the patient is totally different. Okay. So coming to the radiology, when you're looking at an X-ray of a bone tumor, there are few things you have to see. First of all, what the tumor has done to the bone, means how the tumor has changed the character of the bone. Then what the bone is doing to prevent that change, means what that bone is doing to the tumor itself. So imagine a tumor which is causing a change in the bone architecture, changing the characteristic of the bone and causing a lysis. And simultaneously the bone is trying to prevent structural weakness by laying out a fresh layer of strong sclerotic bone around that lesion. Okay, so there is a lytic patch, but around that there is a well-defined sclerotic patch. So you can, on X-ray itself, you can clearly demarcate where is the tumor ends and where the reaction of that bone starts, and it is very thick bone. And it is an incidental finding, means patient is not having any inherent symptoms. So if there is a well-defined lytic lesion with a well-defined sclerotic margin with minimal or solid periosteal reaction, then more often than not we are dealing with a benign bone tumor. Okay, but if the margins are permeative, means on an X-ray you are not able to make out till what extent the tumor is, means where the tumor ends and where the normal bone starts. It's the margin is hazy. There is no sclerotic rim is there, means the body is not able to mount a reaction to that structural discrepancy. Okay, and in the X-ray itself you are able to see a soft tissue component, means the tumor is lying in the bone itself and some part of it is lying superimposed in the surrounding muscular structure. Then these are the signs of aggressive tumors. Okay, if it is a soft tissue component, if the margins are permeative, if there is no sclerotic margin, then these are some of the signs on X-ray itself which will hint that this is something which is not a relatively benign swelling. It might be either an aggressive tumor or it is a malignancy. Okay, so age, as we had discussed previously, age also matters. So well-defined lesion in a age group of 0 to 10. Suppose it is a diaphysis. A mother brings a child, okay, with a sudden fracture of the bone of the humerus. When you take an X-ray, there is a well-defined lesion, okay, and there is a relatively undisplaced or a minimally displaced fracture is there. The well-defined lytic lesion is there. There is a sclerotic rim is there. Then more often than not, it is a simple bone cyst. Simple bone cysts are mostly treated conservatively, especially in upper limbs, unless and until they are in weight-bearing areas of the bone where there is an inherent tendency to fracture. Then only go for a surgical management. Okay, and more often than not, simple bone cysts do not require a biopsy. So these are one of the no-touch lesions. So if a child has an incidental finding of a lytic lesion with a well-defined margin, and when you further investigate, the lesion is completely cystic. On an MRI, there is a cystic lesion is there. There is no area of aggressiveness are there. There is no solid component, and the lesion is completely encircled by a sclerotic margin. Then the diagnosis is going to be simple bone. So you're not going to confirm it with a biopsy. You're going to just keep the patient on follow. Okay. Same way, if the child is 10 to 20 years, there is a lytic lesion which is arising in the cortical bone with a well-defined sclerotic rim, then it is again a benign disease. Okay, so on X-ray itself, sometimes you are able to make a diagnosis. So these are some of the findings. So in one you see there is a lytic lesion is there. Okay, so here this is the tumor which has completely destroyed the bone. Now look here, you are able to make out till where the tumor is extending, and this is the reaction of the bone. So the body is trying to contain that lesion, and it is laying down sclerotic bone around the tumor. Same way, if you see over here, this is the lesion. You are able to make it out completely, but there is a very well-defined sclerotic rim is there, and there is some thickening also is there. Moreover, although there is expansile lesion is there, but there is no soft tissue component in the X-ray itself. There is no periosteal reaction. Okay, so this means that lesion on X-ray is completely confined to the bone. So then these are the signs that more often than not this is going to be a benign tumor. Although some aggressive bone tumors at the initial presentation might appear to be benign. Okay, so it is a more of a clinical judgment, even though on X-ray it appears benign, but if the lesion is very large, then either way you're going to go for a axial imaging in the form of an MRI just to confirm what exactly is there. And if on the MRI, because see, benign tumors, if they are aggressive benign tumors, now the X-ray might appear benign, but the MRI will tell you the clear picture. Means, suppose on the X-ray you are able to measure that the lesion size is 4 centimeters, but on the MRI you see that the marrow infiltration is going up to 6 centimeters, 7 centimeters, then it is an aggressive tumor. So then it warrants further investigation and confirmation with a biopsy. But if the size of the lesion, the extent of the lesion is similar in MRI and X-ray, and there is a well-defined demarcation zone is there, and the sclerotic rim is there, then more often than not, you will be able to make a diagnosis of a non-ossifying fibroid depending on the characteristic of the signal on the MRI. Okay. Now, compared to that, you see, look over here. This is a lesion in the distal femur. This is the physeal area, physeal bar. This is the lesion. Now here you are not able to make out till where the tumor is. Okay, and look over here. The tumor is extending in the soft tissue. Okay. Similarly over here, this is the tumor. You are not able to find out till where it is exactly extent is there. There is a periosteal reaction is there, and there is a soft tissue component is there. Okay. So then this denotes aggressiveness. So soft tissue component, laminated or broken periosteal reaction, permeative margins, okay, and matrix. Matrix means the characteristic of the lytic component. Means if there are bony tissue inside that lytic lesion, it will be sclerotic. Okay. Then there is something called a ring and arcs kind of calcification, which is seen in chondrosarcomas, where the tumor which is there, the cartilage forming tumor which is there, its margins, its borders will have calcium deposition, which will lead to characteristic popcorn type of appearance on the X-ray, ring and arc. So then it is one of the diagnoses for chondrosarcoma. So if these are present, then it is an aggressive tumor, and you are going to go for a biopsy. See over here. Now this is what I was telling you, chondroid. So there is a ring and arc kind of calcification. Here this is ring and arcs, means this is the ring. Okay. Now here you see there is a diffuse permeative lesion, and inside that lesion there are patches of lysis, there are patches of sclerosis are there, but there is no particular pattern to it. So this is an osteoid matrix. Now here there is no matrix, means the tumor has completely eaten into the bone. There is a well-defined sclerotic margin, but inside this tumor there is no bone laying capacity. Similarly over here also, it is completely eaten into the bone. The difference between this and this, what is the difference? There is no sclerotic rim, no? See here you are able to see this is a sclerotic rim, and I marked it with a marker also. This is a sclerotic rim. Here there is no sclerotic rim. You are not able to completely make out till where the tumor is extending. So if there is no sclerotic rim, then aggressive lesion, right? Then the periosteal reaction. This is solid, lamellated, usually Ewing sarcoma, osteomyelitis, spiculated in Codman, osteosarcomas, and rarely in Ewing sarcomas also. Okay, so these are some of the things which we try to see in X-rays. So this is, what is this type? Bolo. It is solid. Then what is this? This looks lamellated. Lamellated means layers of tissue like onion skin. Onion की तरह ना. तो ये ऑनियन जैसा लग रहा है कि ये ऑनियन जैसा लग रहा है. इसमें 1 2 3 लेयर तो दिख रहे हैं भैया मेरे को. नहीं? This is 1, this is 2, this is 3rd. Whereas here you are not able to define everything. Na? This is completely solid. Okay. And this is Codman's. Okay. This is again cortical destruction. So why MRI? MRI tells you the origin. Means whether the soft tissue tumor has gone into the bone or it is a bone tumor which has gone into the soft tissue. Okay. Then amount of extent of the tumor. Like in X-ray, you might not, because it is a permeative lesion, you might not be able to definitely demarcate till where the lesion is extending. And skip lesions are not many a time visible because marrow changes are not picked up on the X-ray. As I told you, for a lesion to be visible on an X-ray, it has to cause at least 30% destruction of the architecture of the bone for it to be just visible on the X-ray. Okay, so that's why you need an MRI, and then we do a biopsy.